Clinical examination of the central nervous system, testing for power in the lower limbs. So the same order of examination is adopted in the lower limbs as with the upper limbs. So inspection for wasting and fasciculation, the muscle tone, power, coordination, and finally reflexes. So fasciculation in the leg muscles may be of no significance, but asymmetry of muscle bulk may indicate a lower motor neuron lesion. Arthritis of the knee may also cause wasting of the quadriceps, but the reflexes are normal and the muscle power, if testable, is also well preserved. A muscle tone is tested at the knee and ankle by holding the leg at the knee and front of the foot and feeling for resistance to flexion at the knee and ankle joints. As in the arm, rigid as extra-pyramidal or spastic hypotonia, that's pyramidal hypotonia, they may be found. So extra-pyramidal or pyramidal spastic hypotonia may be found. So first, we test for the power in the lower limb as a whole, and then test for power compartment by compartment. To test for extension of the hip joint, you place the right hands on the anterior aspect of the thigh, and you let the patient push against the resistance of the hand. You test to test for flexion of the hip joint, you place the right hands on the posterior aspect of the thigh. You let the patient push against the resistance of the hands. Now you place the hand on the medial aspect of the thigh and then get the patient to push against resistance. For tests for adduction of the hip, that's AD, adduction of the hip. And also to test for abduction, that's 8B, abduction of the hip, you place the hand on the lateral aspect of the thigh and let the patient push against the resistance of the hand. To test for extension of the knee joints, flex the knee joint a little, and you place the right hand on the middle of the anterior aspect of the leg, and then let the patient push against the resistance of the hand. To test for flexion of the knee, you flex the knee joint a little, and with the right hand on the posterior aspect of the leg, you try to straighten the lower limb while the patient resists the action by flexion of the knee. To test for dorsiflexion of the foot, you place the right hand over the dorsum of the foot while the patient pushes his foot against the resistance. To test for plantar flexion of the foot, you place the right hand on the sole of the foot and then you let the patient push against the resistance. Again, you compare both limbs when testing for wasting, fasciculation, tone and power, as well as reflexes. Assessment of what is normal in terms of muscle strength is largely acquired by experience, but comparison of the normal side with the abnormal is useful in detecting slight weakness. The evaluation of the muscle power should be recorded quantitatively using the grading recommended by the Medical Research Council (VIS). Grade 0, the activity is total paralysis with no active contractions. Grade 1 is visible palpable contraction without active movement. Grade 2, movements which is possible with gravity eliminated. Grade 3 is very weak but power just able to overcome gravity. Grade 4 is weak, but the power is sufficient to overcome gravity and slight resistance. Grade 5 is normal power. So it's often helpful to also assess upper neuron lesions especially in the lower limb, in terms of disturbance of function. So how far can the patient walk on the flat, and can he manage stairs um, or getting out of bed? What appliance, stick, crouch, frame is necessary for walking? Or tenderness to palpation of a weak muscle may occur in some neuropathies like alcoholic and inflammatory diseases of muscles, for example, myositis.